A very good afternoon. So my topic for today is optimizing hemodiafiltration, a clinical approach. As we all know, the global burden of CKD and the mortality and morbidity that it carries with it is very high. And what we are trying to achieve is a reduction in the mortality and morbidity in patients undergoing hemodialysis. So came the concept of adequacy, whether we are giving an adequate dose of dialysis or not. And the most prominent trial, that is the hemo trial that was done to look at the adequacy of hemodialysis, looked into the KT over V, which is the urea clearance, basically. And unfortunately, it was a negative study. And it had showed no mortality benefit in patients who were able to achieve a higher KT over V. Then came the concept that beyond urea, there are other uremic toxins and middle molecules which may be contributing to the morbidity and mortality in the patients on hemodialysis. So as we look at the native kidney nephron, the first part of filtration is through the glomerulus. There is an intraglomerular pressure which causes ultrafiltration and solvent drag along with the fluid, which is the convective type of transport. And the diffusion that occurs in the tubules is either active or passive transport of solutes. And with hemodialysis, we are only able to target the diffusive clearance. So with this came the concept that convective clearance would help in clearing much more solutes and middle molecules in dialysis patients. So in 1975, Henderson et al. Reported results of a modality based on pure convective transport, that is hemofiltration. And they have shown that there was a lot of middle molecular clearance beyond urea in these patients. And then came the first clinical experience with hemodiafiltration in the late 1970s by Leber et al. In Germany. So coming to the definition of hemodiafiltration, it was given in a consensus conference in 1993, which is defined as a treatment combining both diffusive and convective transport through a semi-permeable membrane of high flux type. And the fluid is removed by ultrafiltration, and the volume of filtered fluid that is exceeding the desired weight loss is replaced by sterile pyrogen-free infusion solution. What is this diffusion and convection? It is, in simple terms, diffusion is where the solutes are transported across a semi-permeable membrane in a concentration gradient. And the molecules move from the area of higher concentration to that of lower concentration on the dialysate side, and they are removed. When coming to convection, it is majorly mediated by pressure. So there is a transmembrane pressure gradient that is created between the blood and the dialysate side, which helps in pushing the solvent across the membrane, and that solvent usually drags the solute, and that is how the larger molecules are able to be cleared. So that is the convection is basically concentration independent and mainly mediated by pressure difference. So the various uremic toxins are classified by the European Uremic Toxin Working Group, and they are still studying a lot of uremic toxins that are involved in patients with CKD, and they have shown 78 small molecules that are uremic toxins, and 12 of them which are middle molecules, and 25 solutes that are protein bound. All these small molecules like urea, creatinine and vitamin B12 are cleared by low flux hemodialysis, whereas the middle molecules like beta-2 microglobulin, leptin and myoglobin, which cause dialysis related amyloidosis and malnutrition and organ damage, can be cleared only through high flux membrane. And the larger molecules like inflammatory mediators, interleukins, TNF alpha and hepcidin and free light chains can be cleared only through medium cutoff membrane. And the larger molecule with 68,000 Daltons albumin, which is a protein, can be cleared only through high cutoff membrane. So in this picture we can see that most of the low flux and high flux membranes used in hemodialysis have only diffusive clearance. And because attributing to the larger pore size, some amount of large middle molecules can be cleared by high flux hemodialysis. But hemodiafiltration has the mechanism of both convective and diffusive transport, and hence it helps in a larger amount of middle molecules clearance when compared to high flux HD. Basic requirements for hemodiafiltration are an RO system which is able to produce ultra pure water, high flux membrane, and a good vascular access with a blood flow of at least more than 300 ml per minute. So how is this ultra pure dialysate or sterile non-pyrogen replacement fluid prepared? The basic RO system, the pre-treatment and the RO membrane are the same for both the loops, but here we can see that there is a difference between the two diagrams here. One is that after the RO membrane, there is a storage tank where the RO water is stored and then distributed to the dialysis machines, and the water that is not used by the machines goes back into the storage tank. So this is a system where there are a lot of chances of contamination at any place in the storage tank or in the loops. Whereas when you can see this RO loop, you can see that after the RO membrane, the pure water comes into the distribution loop and goes to the dialysis machines, and the water that is not used by the dialysis machines goes back into the RO and not into the storage tank, which will prevent infection in any place near the loops, and will help in producing much more ultra pure water and sterile water. So this is a small snippet of our department hemodiafiltration unit. This is the unit, and we have a separate RO room for producing pure water. And here we can see the loop system. This is the loop where the pure water goes into the machines, and whatever is not used will come back into the RO machine and be filtered again. So this is how we try to prevent infection in the HDF unit. Coming to the blood circuit and the basic circuit of hemodiafiltration, here we can look at the HDF machine, which is a Fresenius machine, and here is the high flux dialyzer, and here is the dry bicarbonate and acid. So the water that is pumped from the RO into the dialysis machine is used to prepare bicarbonate and acid concentrates, and the dialysate is prepared with it, and this goes into a filter, which is a bacterial and endotoxin filter, and this is one of the filters that will produce ultra pure dialysate. And after the first filter, the dialysate goes into the membrane, and some of the fluid goes into the second filter, where it is filtered again to produce pyrogen-free replacement fluid or substitution fluid. So there are two filters inside the machine to prevent any contamination into the substitution fluid. So this is the water quality that we try to achieve in hemodiafiltration. The ultra pure dialysate should have a bacterial colony forming units of less than 0.1 and endotoxin level of less than 0.03. And for substitution fluid infusion, completely sterile and undetectable levels have to be present. And according to the European guidelines, less than 10 to the power of -6 colony forming units are acceptable, and less than 0.03 of endotoxin levels is acceptable. The different types of hemodiafiltration. One is the classical hemodiafiltration, which requires bags to be attached to the machine with substitution fluid, like how we do it in CRRT. But most of our machines are online hemodiafiltration, where the machine itself prepares fluid. The fluid that is prepared by the machine is used for priming the circuit, for the dialysate, and also the substitution fluid, and when the blood is returned to the patient. So no saline is used even to give, if you want to give boluses also, the same fluid can be given as bolus to the patient. And the substitution fluid that is given in the hemodiafiltration, it can be given in different places. So the first one is the post dilution. That means here in this picture you can see the dialyzer filter, and here the substitution fluid pump is present after the dialyzer filter. So this is the post dilution substitution fluid. This is the most commonly used and most efficient for solute clearance, and because there is no dilution of blood, and the relative volume of substitution fluid is also lower when we are giving it post dilution. But the cons are that because it is given after the filter, there can be some hemoconcentration and increased viscosity, and the pores in the membrane can get blocked, and which can increase the transmembrane pressure. Then is the pre-dilution, where the substitution fluid is given before the blood enters into the filter. This is useful when there is a limited blood flow rate and in patients who have hyperviscosity. But the disadvantage with this is that the solute clearance reduces, because the fluid that is entering into the filter is very dilute, and the solutes are also diluted. So the clearance is reduced, and also the volume of substitution fluid is much higher, twice that of the one that is given in post dilution. And then there is mixed dilution, which is not available to us in India. It needs an extra technical appliances, like 2 pumps should be present, and also there should be software to adjust the pre and post infusion rates. So in this, the blood can be given in percentages. We can try to give 30% pre-filter and the rest 70% post-filter, or accordingly we can adjust according to the patient. And there is mid-dilution. This is also not available in India. It requires a specialized dialyzer itself, where the substitution fluid passes in the middle of the filter, and the blood goes in the peripheries. So basic cons of this mid-dilution filter is the cost and availability of the filter. So what are the clinical benefits of hemodiafiltration? It has a better middle molecular clearance, phosphates, and advanced glycated end products. The pro-inflammatory mediators and cytokines like complements, FGF23, leptin, and light chains can also be removed. It reduces the intradialytic hypotension, because the replacement fluid is relatively cold, and it also removes many of the mediators of vasodilatation. So it provides a better hemodynamic stability and also has a cardioprotective effect. It also helps in reducing neurological symptoms like restless leg syndrome, peripheral neuropathy, and pruritus, owing to the better middle molecular clearance. Also helps in preserving lean tissue mass, and in children undergoing dialysis, it can reverse uremic growth retardation and promote catch-up growth. So the basic indications for hemodiafiltration are if a patient is having recurrent episodes of intradialytic hemodynamic instability during hemodialysis, or treatment-resistant hyperphosphatemia, any cardiac complications, calciphylaxis, protein energy wasting, growth retardation in children. And it can also be used as an elective therapy for index patients to prevent severe complications, or before any severe complications develop. How do we prescribe hemodiafiltration? So the basic thing that we need for hemodiafiltration is the target convective volume, which is around 24 liters per treatment. And in the next slides, we will discuss why we have arrived at this number of 24. And the substitution mode most commonly is post-dilution. The treatment time is the same as conventional hemodialysis, around 4 to 5 hours. And the blood flow rate, the minimum blood flow rate of 300 and more is optimal for hemodiafiltration for better convective clearance and solute removal. And the dialysate flow is usually 1.5 times that of the blood flow. A high flux dialyzer is required, and anticoagulation with regular heparin. So what is this convective volume? This convective volume is basically the sum of substitution fluid and the net ultrafiltration. So it should be at least 20% of the total blood volume processed. And this convective volume is basically dependent on the filtration fraction, the time on dialysis, and the ultrafiltration rate. So if we consider a patient is able to have 300 ml per minute of blood flow in a given time of 4 hours, that is 240 minutes, the total blood volume that is processed is 72 liters. And 20% of that is a minimum, at least 20%. So that comes to around 14 liters per minute. So this is the minimum amount of convective volume that is required per session. But is this 14 liters of convective volume enough for adequate solute clearance? That is studied in a lot of randomized trials where they have looked at the dose-response relationship. And they have compared a lower convective volume with higher convective volumes and seen which one is doing well. So in this graph we can see that the relative risk of mortality is reduced when the convective volumes or ultrafiltration volumes is higher. So, but they have tested till 25 liters per session. So is 30 and 40 liters per session much more better than 25 liters? That question can be answered here, where they have seen the relative survival rate. So what they have seen is that around 72 liters per week, that comes around 24 to 25 liters per session, was good enough, and beyond that there was no increase in the relative survival rate. So that is why we have arrived at the number 24 to 25 liters per session of convective volume. These are the clinical trials that were done where hemodialysis and hemodiafiltration were compared. And they have studied both low flux hemodialysis with hemodiafiltration and high flux hemodialysis with hemodiafiltration. So among all these studies, only Ishal's study, which was done in which was published in 2013 JASN, with 906 patients, had shown, with the convective volumes of around 23 to 24 liters, had shown a lower risk of overall mortality in the HDF arm. However, did not find any significant reduction in CV mortality. But the study had taken slightly younger patients and those with those who were fewer diabetics and had low comorbidity index and fewer with central venous catheters. So this could be slightly biased, and this is the study that was one of the positive studies, that is the CONVINCE trial. This CONVINCE trial is a very recent study which was published in NEJM in August 2023. So this CONVINCE trial is a multinational open-labeled randomized control trial which involved 1,360 patients and randomized them into hemodiafiltration with high volumes, more than 23 liters per session, and hemodialysis with high flux membrane. So what they have found is that the death from any cause or all-cause mortality was significantly lower in patients undergoing hemodiafiltration when compared to hemodialysis. However, they did not find any difference in the death from cardiovascular cause, fatal or non-fatal cardiovascular outcomes. There was no difference. And they also found that death from infections was slightly lesser or significantly lesser in patients on hemodiafiltration when compared to hemodialysis. So the overall all-cause mortality and infection rate was lower in hemodiafiltration group when compared to hemodialysis. So I would like to talk about NIM's experience with online hemodiafiltration. So our online hemodiafiltration program started in February 2022. We expanded from 5 to 10 machines and a dedicated closed loop RO system, catering to both outpatients and inpatients with around 25 to 30 sessions per day. So we also did a cost analysis for comparing hemodialysis with hemodiafiltration. Excluding the manpower cost, it was coming to around 1,397 for hemodialysis and 2,376 rupees for online hemodiafiltration, with a difference of 1,000 rupees. And the patients who were on hemodialysis, most of them had a government funded scheme like Shree, whereas the online hemodiafiltration was not being funded by the government. So most of them were either paying patients or those who had other credits like Singareni or electricity department. We also have some unpublished data that we have collected from our HDF unit. So we have taken equal number of patients from HD and HDF recruited in the same period in a 1:1 fashion, and we have assessed their baseline characteristics at baseline and also at 6 months. So we have looked at the clinical parameters and the solute clearance and volume status of these patients. So here we can see in this chart, we have in group A, that is hemodiafiltration, around 34 patients, and group B, 38 patients on hemodialysis. So there was a significant patient reported post-dialysis fatigue, nausea and vomiting, loss of appetite, and bone pains, pruritus were significantly lower in the hemodiafiltration group when compared to the hemodialysis group. We did not find any significance in paresthesias, insomnias, and cramps. And we also looked at their hemoglobin levels. The baseline was around, the mean of 8.5 milligrams gram per deciliter. And at 6 months, patients on hemodiafiltration had a significant improvement in their hemoglobin levels to around 10.3 and 9 in hemodialysis unit. But as we have already discussed, the patients on hemodiafiltration were able to afford an additional or adequate dose of erythropoietin owing to their financial status when compared to hemodialysis patients who were relying on the government funded erythropoietin that was being given to them. We also looked at the beta-2 microglobulin levels, which were significantly reduced from baseline to 6 months in the HDF group and not much difference in the hemodialysis group. We looked at the rate of hospitalizations, there was not much difference between the two groups. However, the ICU requirement of patients on hemodialysis was much higher than those with hemodiafiltration. And most of the patients who got admitted, who were undergoing HDF, had infections as the most common complication, that is LRTI, whereas patients on hemodialysis had more acute decompensated heart failure in the form of accelerated hypertension causing pulmonary edema and acute LV dysfunction. So with this we can say that there was better volume control in patients on hemodiafiltration when compared to patients on HD. And they also were able to achieve better hemodynamic stability. Instability was seen in only 23.5% on hemodiafiltration, and the rate of intradialytic hypotension was significantly lower in patients on hemodiafiltration. And also intradialytic hypertension was significantly lower. We also looked at the hsCRP levels to assess the inflammatory markers, and which had significantly reduced from 36.2 on an average to 5.2 at the end of 6 months in HDF. We also assessed the quality of life, but it was actually better in hemodiafiltration, but we should take it with a pinch of salt because most of our patients, there is a selection bias because patients on HDF had better financial stability, and they had a good family support, and the patients on hemodialysis, most of them were breadwinners for the family, pushing them into a financial crisis, and which had affected their quality of life. To summarize, the significant differences, statistical significance was found in patients in dialysis tolerance, reported symptoms, anemia control, beta-2 microglobulin clearance, better volume status, hemodynamic stability, HSCRP levels, and quality of life. And there was no significant difference in the nutritional status. The calcium, phosphorus, actually there was a difference, but it was not statistically significant. And the PTH and vitamin D levels, hospitalization rates, and albumin and lipid profile, and left ventricular ejection fraction. So, concluding the talk, learning points from this would be that in the state of Telangana, actually we have a very robust dialysis program with hub and spoke model, where we are able to cater to a lot of hemodialysis patients, even in remote centers like Adilabad and Utnur. And there is much more accessibility, availability, and affordability for hemodialysis. Though hemodiafiltration has reported better quality of life, hemodynamic stability, and middle molecular clearance, considering the cost and availability of the machines in the government setting, it may not be for everybody. Maybe we have to tailor the therapy to each patient individually, and initially we could put them on low flux hemodialysis, and then probably shift to high flux hemodialysis, and then consider hemodiafiltration in them when there is a lot of middle molecular accumulation and symptoms. So that could be much more cost effective in the government setting in Telangana. So further studies, we are planning to do a head-on comparison of online hemodiafiltration with high flux HD with a double pass RO, and hemodiafiltration in the acute care setting. So with this, I would like to conclude my talk. Thank you for the opportunity. I would like to thank Hyderabad Nephrology Forum for giving me this opportunity. Thank you.
Dr. Wellington, I want to ask you. We have, actually I practice in Karimnagar, which is 4 hours drive from Hyderabad. It's a big place. So we got HDF machine 4 years back, before COVID. And with very little experience we got that, because every case which was going on to hypertension, we are unable to dialyze. So I understood over the last 4 years, it's a boon, I think, for our patients. I've stopped referring any patient. If any patient is not passing through HDF, probably will die en route, because the patient is such a refractory shock. So what I learned from this HDF and what discussions I had today morning, I understood that the clearance is depending on convection and time. Yes, sir? So what, after this online HDF, I want to clarify what we are doing is correct or not from you, sir. So what we are doing is online HDF. So there is unlimited supply of that water, where you can do unlimited convection based on that. So we have reduced the time. The time factor which is there in CRRT, here we have got less time, but we are doing more convection. So my doubt is, most of the cases we are doing in hemodynamically unstable patients, that is one thing. So we are putting the central lines where we don't get that effective blood flow. So the clearance in HDF is dependent on the blood flow, which is mentioned again and again. Then second thing is, sometimes we are unable to put the jugular, we are going for femoral, where there is access recirculation. And again, in patients with having low blood pressure, hemodynamic unstable, are we doing it right in holding on to patients? That is one thing.
Yes. Actually, the earliest study on using this online hemodiafiltration in acute care setting is 2004. It's come from the Mark Marshall's group in New Zealand. They had reported it, and that was at that time the 5008 machine was not even marketed. So they used to do it with a machine called ARRT Plus from Fresenius. Yes. I also started doing it 15 years ago with an ARRT Plus machine in 2007 in the ICUs. Now in that paper from New Zealand, what they did was they set the convective volume at 100 ml per minute, and they set the dialysate flow at 200 ml per minute. So 100 ml per minute is 6 liters per hour. So you get, and they were doing 8 hours sessions.
Okay.
So they would be getting about 48 liters of convective clearance in that setting. And in now with 5008, life has been made easier.
Yeah.
You can go down to 100 ml per minute dialysate flow. You can set, I think what will determine the duration is how much ultrafiltration you want to do and what rate of ultrafiltration your hemodynamically unstable patient will tolerate. So the data says that if you increase the ultrafiltration rate to more than 1 point, convection will be the same. You can deliver the same amount of convection in both situations. The volume of convection will increase as you increase the length of your session. But not producing hypotension, if that is important, you will increase the duration of your session to limit the ultrafiltration rate. Yeah. So in that case, if you target a total convective volume, then what you could do is you could reduce the convective flow. The 5008 machine allows you to go to as low as 25 ml per minute. So that is just 1.5 liters per hour. And you can go to as high as something like I think 200 ml per minute, which is 12 liters per hour. So what the simplest way to do it is, if you want to optimize convection, decide your duration on the basis of hemodynamic stability and then use the auto subflow function. So the machine will determine the optimum convective volume so that your circuit does not clot.
So mostly we are running on auto subflow.
Yeah.
It is like default prescription.
Yeah.
There were not much efforts are required from the nephrology
Yes,
side.
absolutely.
So the technology is simple. It's as she mentioned here, it requires 2,500 for the consumables.
Yeah.
We charge 4,000 for the procedure,
Yeah.
and then total it is 6,500 only. And with the same scheme, what is it, RBC program, we just charge extra for these things, and patients are convinced about that we are getting
Yeah.
results. Another question, sir, is patients who are hemodynamically stable also.
Yeah.
Like when patient is on ventilator,
Yeah.
so they are also using it.
Yeah,
as
so
a
am
check,
I.
like, yeah. So where the convection will help in the same concept what they are saying in CRRT since morning.
Yes.
Same concept we are applying in patients like
In fact,
postpartum
what you are
API.
doing here is high volume hemofiltration.
Yes, sir.
So you may have to actually tell your intensivist increase the antibiotic doses. Based on what Dr. Ashekar said this morning, that for every 10 liters of convective volume, you need to increase your GFR by 7 ml. So
Okay.
you will have to increase your antibiotic doses in this situation, because what you are doing is high volume hemofiltration. So it will remove a lot of bad things, but it will also remove some good things like antibiotics.
And again, it's an intermittent procedure.
It's
so
an
in between
intermittent.
You can replenish all
So
the
it's
other
it's a
things.
form of prolonged intermittent renal replacement therapy. And as I said this morning, in the meta-analysis done by Zhang 2 years ago, it was shown to be the only modality which reduced mortality. Till date, no modality and mortality, there is no relationship according to all analysis, except in that meta-analysis which showed that SLED-F, which is what you are doing,
Yeah.
reduced mortality by
But
31%.
we are in somewhere in between, not going to the extreme and all that.
Yeah.
And one more thing, sir,
It
regarding
is certainly cost effective.
Yeah.
Even patients on 3 pressors tolerate it well.
and also in poisoning cases also we are using for paraquat poisoning, where ours is the first.
I have no experience of paraquat because
That
we
is
don't
also
get
helping
many.
us. After
I guess it would work.
Hemoperfusion 2 times and hemodiafiltration, it is working well. sir.
3 times a week with
Thanks.
routine hemodialysis. If at all you have a good blood flow of 300, you dialyze them adequately for 4 hours. It is actually as equivalent as hemodialysis filtration also. So we need to select the patient, because we had an ethical question. If at all we are promoting HDF and we are having a strong, the outcomes which are much better. So why should we stop funding these patients through the government? If at all online hemodiafiltration is offering the outstanding benefits, it is statistically significant in improving the mortality, then we should ban this routine hemodialysis and we should go for convert all these patients to online hemodiafiltration. But it is not so, as of the literature shows, as sir may agree with me, with online hemodiafiltration though has advantage in some selected indications, but routine hemodiafiltration, you are doing 4 hours per week, 300 ml blood flow, optimizing everything, I think this will be sufficient number to improve the mortality and morbidity in the routine patients. And regarding the online hemodiafiltration, if at all you can have a sequential therapy, you do, like if at all you have a residual renal function for a few years, you can bank on that and you can do a routine hemodialysis. Later on, once patient loses residual renal function, he accumulates middle molecule, then you can step in and convert them to online hemodiafiltration. That's a cost effective method, because just postgraduates are there. I just want to make it clear that whatever hemodialysis what we are doing 3 times per week, 4 hours per session is very good to improve the mortality and morbidity. So for that actually we need to monitor whether that is being delivered to this patient or not. If they are very clear on that, then mortality is similar in online HDF and HD. And a lot of other improvements are also coming, like establishing HDF requires a lot of the other investment also. We need to have a separate RO plant, separate piping, separate machine, the disposables are also there. And people are coming with different membranes now. They're also coming super high flux membranes. Theranova and Elisio from Nipro, they're comparing this super high flux where you can use a routine hemodialysis machine. Because hemodiafiltration, you require a separate machine which is double the cost. It is costing on 13 lakhs. Hemodialysis machine only 5 lakhs. So let us say you have same RO plant, and if at all you want to do convective clearance, you can use a different membrane with the same machine, same RO plant. You have super high flux membranes which are coming to the markets. I think the studies are still going on. Yeah, because the other studies are going on where actually they may come out using the same dialysis machine, using the same RO plant, just changing the membrane. We can have the not higher but maybe equivalent to the online hemodiafiltration outcomes which we are trying to have through the convective clearance. I just wanted to ask Lobo, Dr. Lobo on his experience or comment on using these super high flux membranes.
Only a small experience so far. We've just started using Theranova, but yeah, it as you pointed out very rightly, you don't need such an expensive machine. You may not need, like for instance, if you're going to do hemodiafiltration, you must have endotoxin levels in-house. You can't be, I will send the endotoxin somewhere else and I'll get a report 2 days later and then I find, oh, it's positive. I shouldn't have been doing hemodiafiltration. So you need your endotoxin levels in-house. You need to have your water ultra pure. And what you showed, that's there. I mean, it's using double pass RO. If we are doing both hemodialysis and hemodiafiltration in the same unit, then the hemodialysis patients don't need double pass RO. The first RO is rejecting 50% of the water. The second RO is rejecting 50% of what is fed to it. So one of the centers which was using it, they were producing 2000 liters of water per hour from a starting water of 8000. So that's as bad as, that's as the amount of water wastage, and they weren't doing HDF on every single patient. So there's a lot of water wastage, there's a cost involved, and I agree with you that the patient who has residual renal function, that residual renal function is doing what the hemodiafiltration will do. It's when he loses the residual renal function that yes, certainly this. Theranova, small experience, we've started trying to use Theranova as a light chain remover in myeloma kidney. I hope it will have good results. Yeah, so the light chain levels come down. We've just done 2 patients till now, and one of them has come off dialysis receiving chemo side by side. But dramatic reduction in light chains. So we do at 1 month of dialysis, chemo goes on side by side, and then we do the FLC again, free light chain ratio. Just like normal MHD. We use Theranova. There's also this question then that comes, the company says it's single use, should we be reusing Theranova? I don't know the answers.
So if we have no more questions,